Presentation will be taken by Dr. Prashant B. Coordinator IPVC, ITRA Jamnagar, Gujarat, on the topic Need and Significance of Therapeutic Monitoring of Ayurveda Medicine Practices. Welcome, sir.
Very good morning to one and all. Professor Ram Manohar sir, Ramesh sir, and Raj Mohan sir ji, as well as Prajit Nath sir and delegates, designatories, I will say, representatives from all 7 districts of Kerala. Very good morning to one and all. I am here to because first of all Dr. Prajit Nath sir gave me a task to how to establish Pharmacovigilance Center, Peripheral Pharmacovigilance Center, Communications and Pharmacovigilance Cell in the college and all those things. But I thought that it doesn't need anything rather than motivation. You have everything with you. It's simply you need to start up with, and that is why I just focus what are the potentials, and to initiate with I have chosen to focus on therapeutic monitoring. So first slide please. So it has well started back since 1664 with thalidomide tragedy, but we don't expect such drastic adversities in case of Ayurveda therapeutics. But where fecomelias were noted in pregnant ladies, and the utmost principle of medicine is please do not harm. The second one. So it doesn't merely with adverse drug reactions and fatality, but mild. Nothing is mild. It depends on the severity and further expression until and unless, and in different cases the mild can be different, and that is why nothing here is a mild. In case of lead toxicity, mere salivation and headache might not be a mild one. In other cases it might be. So the strength depends on what you are dealing with, and that is why it is not only capturing only fatalities and alarming signs and symptoms, but it needs a robust protocol to monitor and report, to identify and analyze. So why reporting of ADR, AD has been given so significant? Because almost 4 to 6 leading cause of death, and almost 50% ADR in hospital are possibility to revert back. Those are preventable, and almost 1 in 1000 death is due to these complications, and around 2% to 6% of hospital admissions are there due to these complications. So I don't say that this statistics is with Ayurveda, but don't be in a very fantastic conception that you don't came across. If we are not monitoring, if we are not focused to identify and analyze, it doesn't mean that nothing happens. There are even fatalities also, and even don't think that like a layman that they will take a time, you will have a window period to monitor and you can modulate. No, it doesn't, it's not like that. Even oral administration of 60 mg per kg body weight of Swarnagarb this which Pottali, Swarna Pottali, Hemgar Pottali, that has prevented even convulsion in a there was a convulsion only in one rat, and none was died while in strychnine group all 6 rats died. So don't think that oral administration only 0.2% absorption of Hg, what report says from Sinabar or HGS or what we call it as. You don't think that less absorption and it will take a long time and long effects. No, it's not. We have came across 3 fatalities, near fatalities, and hardly we were able to survive. So all those were accorded to Vatsana, but still those are there. And to ensure safety of patients on drug, to reduce economic burden of nation as well as society, and identify risk factors. There are genetic variabilities. Now the medicines are globally, global market is being expanded day and onwards, and in different races, different lifestyles are there, different ethnics, different response to drug is different. So pharmacogenomics is now emerging, and individualized therapies are now being emerged. The response of drug might not be same in all individuals and races. So you must to monitor the safety. If for Indian population the drugs are safer, it doesn't mean that those are safer all over. Those who are not throughout their lifestyle, those who have not never consumed turmeric and lashun, the doses might be different. The doses which you are daily consuming might be an irritant or may exhibit significant interactions. So those are potentiators, biopotentiators, enhancers, and multiple drug-drug interactions are possible there. So the main thing is poor patient compliance, because in a society it is considered that most of the traditional medicines, herbal medicines, those are safer, nothing happens with them. If we are in this conception, our medicines should not work at all. If those work, if those are not properly properly used, even with the water administration of water, you can commit a suicide, and you can it can be a fatal. So what is about then the drugs? We are dealing with drugs. So it is handling which defines its chronicity and tendency to adverse drug events. So data generation is used for policy developments and safe uses of medicine, as well as precise medications and accurate medication is also a motto. So next one, third one. So it is bifurcated, previous one, bifurcated into two parts. Yes, thank you. This is forward. Okay. So therapeutic protocol monitoring for procedural monitoring and drug monitoring. Therapeutic drug monitoring. I don't think there are questions over safety of Ayurveda medications. PCRS had 13 publications, and in one publication there are again 13 formulations evaluated for toxicity studies. All are toxicity studies, and we do have also 3 monographs with us: Nag monograph, Raskarpur monograph, Ras Sindur monograph, and several studies. More than 35 toxicity studies have been conducted at ITRA on Rasaushadhis. So you can see up to 5 times TED there are no changes. Even in 10 times TED there are no changes. Histopathology, hematology, anything, you don't find anything. If something is there in 5 TED or 10 TED, it is reverted into recovery group. So there are mere explanations, and for one only observation, if we get something for Rasmanikya when it was administered with CMC, we try it with multiple ways. We again do it with honey, and there were no toxicities. And again, if something was there with Somnathi Tamra Basma, again some queries were there in histopathology. So we repeated it with Amrutikaran and with modulations, and then 5 times and 10 times TED we found nothing. So where there, if single suspicion is there, we try it in multiple ways, and one study means there are lot of formulations. It is not only a Makardaj. Makardaj prepared with Sarnapatra, Varka, Basma, and lot of, and then 2 to 3 such trials will also be there. So it is just counted as one study. So most of the Basmas and few Rasaushadhis are also there over, and with different modulations. Nag Basma 10 putti, 30 putti, 60 putti, 100 putti, Garbhapal Ras prepared from 100 putti. All we have the data of safety that at least at therapeutic level, we didn't came across any type of hazard. Even genotoxicity studies, more than 7, and 7 are again in pipeline. Genotoxicity studies, chronic toxicity studies are also there. This is online publication. 11 acute toxicity studies of 11 basmas of metallic origin. Only metallic origin. Other Rasavarga Dravyas and those are not included here. So publication is online, and almost every study it is there in online. So but still conveying safety of mercurials, metallomineral medications, Rasaushadhi is not an easy task, because there is huge lobby, huge data, huge scientific documentation, because it has been piled over decades. against in support of their toxicity of these heavy metals. Because why? Because industrialists, economists and scientists of varying sectors, everybody was involved in this, because pharmacoeconomics was involved, because it was in a trade. This medicine, their compounds were there in trade. Economics was involved, their safety was involved, human rights were involved, their people were involved, worker laborers were involved, human rights were involved. It was sold over countries globally, so international norms were there, and that is why huge data was generated in support of toxicity of heavy metals. And I'm of the agreement that nothing is wrong, everything is right. But still, if you want to say that we use it safely and efficaciously, the data, parallel data should be more strengthened than this one. You cannot have with such tools. You should have very strong data, and this we will see that it is not sufficient one. What we have done is not sufficient one. We know that merely talking in a closed room, that we prescribe in 2017 for only 3 days, we have data of 1,800 patients over only 3 days monitored. I have not kept the slides here over. There was OPD of 1,000 a day and 33% rate of prescription of mercurials. Every day 300 patients were consuming, and there were patients over more than 6 months, 9 months likewise, and there were cases, but we were hesitant to, and we have not came across any publication. For 5 years, 7 years, a 70 years old lady, Navjivan Ras, an alcoholic patient with Arogyavardhini Ras, 5 years continuous administering. There may be gap of few weeks on and off, but all documentations, LFT, KFT, USGs, and all were there. So I don't say that with same drugs of Swaskutar Ras, Tribhuvan Kirti, even Tribhuvan Kirti, the classical dose, if you it is 1 Rati, we have given 12 tablets a day of 250 mg for a month in a patient of bundle branch block with safety, with continuous monitoring of ECGs and parameters. Nothing has, but I don't recommend to do this. But with the same drugs, there are fatalities also. With Swaskutar there are fatalities. With Tribhuvan Kirti there are fatalities. With Sanjivani there are fatalities. The conditions must be identified, and sporadic and reporting, spontaneous reporting doesn't serve this purpose. Either it should be a very stringent monitoring or a systematic documentation, systematic monitoring. There must be a protocol to identify which conditions, which combinations of permutation combinations lead to this toxicities. So, and that is the sector of therapeutic drug monitoring. And as we told, nothing is safe. And as we told that we do have our data of evaluation of safety is insufficient. Because why? There are several reasons for that. Because for conventional medication, preclinical studies, kinetic, bioequivalence studies, and all are compulsory. There is systematic development of drug through in vitro phase 1, phase 2, phase 3, phase 4 trial, and it is not mandatory for us. In vitro safety protocols, drug interaction studies, everything is kinetic, toxicokinetic data, everything, carcinogenicity, genotoxicity, everything is recommended, and that is why the proof of safety and specificity, accuracy is more. And as it is there already in the domain, public domain, and in practice, it is not well documented and identified. So, recommended duration of toxicity is these heavy metals, they tend to accumulate over years together, decades together. So the data is not, scientific community will not accept a data of 9 months observations, 3 months of 6 months observation toxicity studies. We do have chronic toxicity studies, but we need data of, we need to modify the protocols, the observation, then recovery group, recovery period, but we do have limitations in animal study. In next data, it is summarized in, I think, in next slide, the lacunae. For chronic toxicity, 1 year data is needed. but 1 year is not sufficient for us. If we claim that it remains for longer time after Trivanga Bhasma administration, every month administration, 1 month, 2 month, 3 month, successive reduction in glycemic control, but the highest glycemic control after without any medication after 4th month, then it is a proof of toxicity, because glycemic interaction with glycemic control and without medication, if it remains there, it is a proof of accumulation, and then you need that. You cannot say that this recovery period is sufficient for you. You have to monitor for long. You have to we have to modulate the trials. There are delayed toxicity reports also. So this is how for decades it can be there. So the monitoring recovery period, the protocols are very much fixed and finalized, and very much in compliance to the definition of modern drug and for modern conventional drugs. But we need to modulate them. You cannot have a for small animal models for rat mice more than 2 year lifespan. You don't have. So you cannot have a delayed monitoring for long time. And for higher animals, again there are ethical consideration, and again there are considerations for translational value of this data into clinics. So you need data of clinical. So recommended protocols, those are very stringent recommended protocols for monitoring toxicity, pharmacokinetic, and male fertility study, female fertility, allergenicity, development of developmental toxicity, carcinogenicity, neurogenicity, immunotoxicity, likewise. But we don't evaluate all those things. Without monitoring, we cannot say that it is not related to us. All heavy metals are reported to be carcinogenic, but we have not evaluated carcinogenicity. We have not conducted separate. Few reports are there on developmental neurotoxicity, but immunotoxicity there are no reports. Likewise, we need to have then 2 species are needed. We don't go for and frequently in most studies up and down methods are not followed. Where we lack that 2 species, number of animals, duration, likewise interim kill, there are some lacunas. And Ayurveda medications or traditional medications are always under scan when there are concomitant administration of drugs, because all data are related to what is the principle of causality, temporal relationship of drug with the drug reaction, and biological plausibility. The tools are documentation, dose response relationship, NOEL level, and data of pharmacology specifications, all are needed, and everything is needed for this drug. So the blame comes to only Ayurveda medications. And as we mentioned that even after long-term administration, even after 5 years, 10 years also, people used to claim that the lead levels may be due to other causes. There are such reports from Hyderabad for Pushpadhan virus. The patient was not conceiving for 3 years, and when she was convinced, with 3 months, 1.5 month administration of Pushpadhan virus, there were 35 ppm of lead levels. But it cannot be due to, because total dose is not administered in that, it is not possible. Within 3 hours it goes into tissue levels, and then it doesn't comes back until and unless there are tissue saturation. So it is not possible, but people used to we are always at blame, and until and unless this is monitored, and with animal toxicities, there are several limitations. So therapeutic monitoring, long-term monitoring is always needed. Documentation of concomitant medications, drug-drug interactions is very important. So until and unless you don't have a data, the safety data, people will have concerns over whether anti-diabetic drugs will cause a hypoglycemia or not. So until and unless you have data of safety of concomitant administration with INR, PTT, PT, where there are in a very small therapeutic range, PT, INR are to be managed. Above 2, it is not permissible. Otherwise, it will be bleeding, or otherwise lead to thrombogenesis. So very biological short, narrow biological levels are to be maintained, and then it is a question whether such concomitant drugs are to be administered or not. I mean, if you don't have a data, nobody will recommend to for concomitant administrations, and the potential of medicines will not be optimally utilized. So with antihypertensives, OHA, anticoagulants, the same thing is there. So there are always pre-metabolic, the basic difference. I think the slide is not there. The basic difference in between conventional medication and modern drug. Our drugs are mostly prodrugs. You don't know whatever you are administering, it doesn't goes into systemic circulation, and whatever it is working, it is not it might not be what is there in the circulation. Secondary, tertiary metabolites and the ligands, what working you don't know. So there are pre-metabolic considerations, post-metabolic considerations, excretion, which alters drug kinetic and drug interactions. So how conventional people will allow to for concomitant administration, and the potentials will not be utilized properly, as well as the drugs will be always under threat for whatever the toxicity, the drugs, Ayurveda drugs will be blamed. And until and unless we don't have a data of this drug-drug interactions and monitoring, we will not be able to, because we cannot conduct several clinical trials with all anupan, with all concomitant drug administrations, and that is why the ultimate answer is therapeutic monitoring. So the monitoring is aimed to assess risk-benefit ratio, to confirm safety and efficacy, to detect less common adverse effects, and what happens with this, it contributes to whether drug is to be withdrawal, modify labeling, or safeguard any contraindications. Cautions are to be added, and identify as vulnerable population or a condition, vulnerable clinical condition, where there are such signals generating. So this can be at the end of monitoring. With monitoring. So in spite of safety evaluation through toxicity studies and reporting of ADR, ADE monitoring, still is it needed? Therapeutic monitoring, is it needed? Yes, certainly it is needed. For toxicity studies, as we mentioned, that the data of clinical data is more important in the level of hierarchy of evidence, and it strengthens, in fact, it strengthens the reporting of adverse drug events and adverse drug reactions, and fulfills shortcoming of most of the widely practiced methods of surveillance for adverse drug reaction monitoring, that is spontaneous and voluntary monitoring. With this, with therapeutic monitoring, you do target monitoring, you target a population, a condition, a research question under whether nephrotoxicity is there, whether it will cause arrhythmia, whether you targetedly monitor, and then the answers are specific. Otherwise, if we are spontaneously, whatever it is being done, it is reported, it will take a long time, and long huge data is needed to generate the signals, and to fulfill this gap, the therapeutic monitoring is an answer. So why specific therapeutic recommendations are needed for Ayurveda medications? We do have a lot of setup that all are to be taken into consideration while prescribing Agni, Koshta, adjuvant, all Dashvit Pariksha, everything. And why not for concomitant contemporary medication? Is it not parallelly applicable for them, and why it is for us only? And this is important, because to avoid the complications, the right patient, right dose, right medicine, this depends on all those factors. And what is right? Then the problem comes. I think I missed the few previous slides. The very definition of adverse drug event monitoring, the basic thing is unintended, unwarranted medication effects in a normally prescribed doses. So what is unintended, what is unwarranted, and what is normal prescribed dose? So to identify this, the therapeutic drug monitoring is more important. I think the slides have been, PPT have been changed, or I have came fast. Those slides have been missed out. So the basic difference is in solubility, kinetics, and the drug interactions. There are more drug interactions with traditional medications or Ayurveda medications. And we expect first pass metabolism in gut, Snehakalpana. Until and unless it is digested, it will not go into the first pass metabolism is expected, which is not expected in case of contemporary medications. Pre-metabolic drug-drug interactions, post-metabolic drug-drug interactions are expected, and that is why the drug-drug interactions are, we expect to alter the action of drug. So there may be interactions with concomitantly administered drugs also. So with this therapeutic monitoring, targeted therapeutic monitoring can be done, and the effects of drug in a specified clinical setup, clinical condition can be monitored. So yes, it is what is unintended. Do we intend some actions of Shukrajanan, Stanyajanan, Rushya drugs in either genders and all age groups, pediatric, elderly, and menarche, puberty patients, and all? So aren't they prescribed clinically to treat other disorders, and aren't they given for Rasayana? So how to define whether the response to medication action was intended or not? For what it was given, whether it was intended or not. So there are defined formulations where nar nari nam, stri nam, rushaitis, which suggest that there are gender specificities, and can mild unintended response to medication undermine? No, certainly as we discussed, it cannot be. With the late toxicity, mere loss of appetite, lethargy, myalgia, can you neglect them? Never, never. And will you watch for drop foot and tremulousness in case of mercury, in case of drop foot, in case of lead, and projectile vomiting in arsenic toxicity, fatigability in Vassanav? Can it be neglected? Because the next moment the patient can go into cardiac arrest. So can mere fatigability be neglected? So what is unintended? Whether this is there is nothing is mild. So continuous therapeutic monitoring creates cumulative data and enriched databases. Primarily, it serves the purpose of safety evaluation and value adds to the subsequent improvement of specificity, precision, and accuracy. And specificity, like Agrasangra drugs we do have, where it acts particularly. Highest dose tends to impart highest efficacy and usually ends in toxicity, and lower dose with therapeutic failure. So precision is needed, and from where it will come? Therapeutic monitoring only. It will define a dose, it will define whether it was intended or unintended. I think again we missed the slides. If we give Bakuchi for Shvitra, local application, systemic application, or phase in a new case, in a chronic more than 1 year, in a static state, or in a exaggerating state, in all states the dose will not be different. Do we don't intend the blisters to happen? With blisters there is more results are there. But are they intended? Are they intended over face? Are they intended in children? Doesn't Bakuchi is prescribed for psoriasis and Twach Vikar and for Rasayan? So is it expected there? So what is intended is it depends on the purpose of administration. So it cannot be a fix. So the therapeutic monitoring can define it, and the doses for all indications and intentions may be different. For Haritaki, if it is given for Virechan, if it is given for Anuloman, it will be given for Vatanuloman, Virechan, Karshan, the same dose, and for Shodhan, the same dose will not be the same. Charvita Agnivardhani, it may be given for Bruhan, it may be given for Karshan, the doses will be different. So it is on whether the effect was intended with the prescribed doses or not. So all the answers will be there with therapeutic monitoring. So it is non-targeted and target distribution, like drug consumption studies, evaluations with schedule 1 drugs, drugs with alcoholism. There is drug alcohol interactions are there. So in alcoholics the response might be different. In lactation, geriatric, critical conditions, Shoth, Gulma, Rudrog, those vulnerable conditions which are prone for toxicity, like drugs prescribed in Kamla. Drugs prescribed, already there is hepatic impairment. If you are giving drugs for Kamla, the enlisting and practices, recording practices is a proof of safety. Drugs prescribed in Rukka Rog, whatever it may be, let it be any herbal drug, whatever you are using for treatment of Shoth along with renal insufficiency, it is a proof of safety. So monitoring documentation is a proof of clinical proof of its safety and doses and mode of administration. So procedural vigilance, everything is there. Samyak, Shodhan, Lakshan, Vapad, all procedures. We do have data guidelines for monitoring. and the safety in prone people of complications. Clinical trials are not permitted here. Or in vulnerable cases, conditions, clinical trials, nobody will allow you to prescribe drugs in diabetic nephropathy, heavy metal administration. There will be ethical considerations. So in collaboration with contemporary ethical committee, it will be again difficult. So renal impairment, liver impairment, G6PD, but therapeutically you can monitor ongoing practices, you can monitor and document, and you can have a research only on in animal studies, but the in vivo maybe it may not be have that much translational value to clinical settings, and the clinical monitoring is only an option in such cases. So drug-drug interactions like chronic conditions with chronic administration and commonly used drug like hypertension, diabetes, stomach swas, amla pitta, ajirna. With this, there may be concomitant administration. Vatsanab, around more than 579 formulations are there, varying concentration from 1 to 80, and this can be for let it be Sutsekar ras, Shankhavati, Swaskutar ras. Same patient may be having amla pitta, likewise this tamak swas, and maybe hypertensive. So beta blockers, calcium channel blockers, or arrhythmias, or drugs for arrhythmias, amiodarone, etc. Those may be patient may be on, and it may be आपने उसी दिन इसका ड्रग ऐड कर दिया और पेशेंट जाके गिरा और उसने केस कर दिया कि आपका the arrest was due to cardiac arrest. You don't have any proof. If there was after administration of Vatsanab, if later on the first degree heart block is noted, until and unless you have documentation, he may claim that the first degree heart block is due to this Vatsanab. If you didn't have an previous ECG before administration, if you don't have any documentation, you never stand anywhere, and it will be there with therapeutic monitoring. So whatever it may be the cause of mishappening, you are always prone, if you don't have a data of these concomitant medications. So several anupan, the bhavna dravya with same anupan may be there, so there may be exaggerated reactions. If same anupan and same bhavna dravya are there may be exaggerated reactions. So academic research works can be a good source of therapeutic monitoring, data generation, and safety evaluation. Statement of probable ADR should be enlisted and adopted, but merely writing that the ADR were monitored and there were no ADR, it doesn't solve the purpose. There is a protocol for monitoring of, it is to be individualized, but there are questionnaires, and it must be there, it should be given, and it is very good source. Even if you just enlist that medications prescribed in pregnancy, medications prescribed and in a doses, medication prescribed in pediatric group, elderly, that is also value add drug. Whatever are the results, outcomes, only the documentation of dose and enlisting of drug could value add to good data of generation of safety. So because these are scientifically validated, approved, and CTR registered trials, and it has its own significance. So the data may be piled up over several years. So safety of Sneha, Tarpan, even people, if you find online, sesame oil, groundnut oil, mustard oil, their adverse reactions are reported with local application, with administration, adverse reactions are appeared, and you administer tens of oils for nasya, it crosses blood-brain barrier, and if you just document that there was no sleeping drowsiness, there was no significant sneezing, there was no neurological any deteriorations, that must be, but what you have monitored, what was the process, what you document, it should be documented. We take it as considered, but when it comes to some complication, people used to tell, okay, with sesame oil application, there is there are chances of say 1,000 in 1, it may be due to this. But with Abhyanga for pediatric, I don't think anybody in this house have came without baby massage. हमने सबने किया हुआ है.
even with pediatrics, if he recommends other people's, he had been underwent through pediatric massage. So the most vulnerable things, but it must be recorded, reported, and documentation is very important, because 12 cases of lead toxicity published in a JAMA, online publication, on online procurement, and with first trimester, it's after chelation, after third trimester, the same symptoms will not be there. The same symptoms, headache, nausea, it will never persist there, and people document it. But the 30 years ago study of BHU with third generation toxicity study, chronic toxicity study of 3 months, and but the documentation and publication, even a publication, scientific evaluation, and a stage of stage where you broadcast or publish, that is also very important. That is not taken that much notice, and this has been made a havoc. So monitoring, scientific monitoring, there must be a protocol for evaluation and documentation, recording. It is more important. Merely saying that we use it, we practice it, we doesn't came across, and we should not just wait for, and this sporadic and spontaneous reporting, it doesn't give prevalence. Whereas targeted monitoring, if let it be retrospective, prospective, it is well defined, and for a particular question, it will generate data of frequency. So neuropathy, it is common for lead, arsenic, lead toxicity, but in cerebrovascular event, Prakshaghat, we used to prescribe many such combinations, and if those would have been worsened, modern neurologist says that after 30 minutes to 1 hour, there is no use of any drug. Penumbra, once you have to only penumbra, you have to take care of penumbra. Whatever it has infected, it will never going to get recovered. So we have to protect only ischemic zone, and with physiotherapy and all, what are the improvements within one month or a couple of months, it will be forever. There will be no improvements at all. There will be no worse deterioration at all also. So there was no deterioration in case of any Pakshaghat or neurological disorder in CVE. It must be documented. We don't mind whether there are improvements or some significant results or not. It doesn't matter. Worsening was not there, because contemporary scientist says there should not be either worsening or improvement. It should be a static. So there was either improvement or static. That is to be documented, and reversal is a proof of safety. Diabetic nephropathy publication from China, in a diabetic nephropathy with lead exposure, the renal function deteriorates, but this is a protocol for administration of madhumeha, nag, trivanga, we do have, and I'm sorry to say that proteinuria and 24-hour creatinine were monitored, and those were it was reversed, but it was not documented, neither in thesis nor in publication. Krishna Kumar Taviad, it was monitored, but it was not published. But and we do have Trivanga study of Trivanga Madhumeha, as we told, for 3 months, and right now 6 month study is undergoing, and 6 month patients are completed. So without worsening of in nephropathy. So it is proof, and then these are ongoing therapeutic monitoring, and for what it needs, I miss I think several slides, what it costs and what it needs. It doesn't cost anything. You do have everything with you utilize all resources, hospital resources, nurses, expertise, doctors, investigation, everything is utilized. Only it needs to monitor, have a protocol, have a initiation, enthusiasm, and documentation. It needs nothing else. So otherwise, the whole system and whole this will be underutilized. The services, medical services, the cost and time and all we are utilizing. It will be it will not an optimal utilization of it. So pathya, apathya, there are several kakarashtak. There are Varja, but same diabetic person consuming mercurial will be consuming carvella, kushmanda, betel leaf. Likewise, all those are along with grape, all those are p cyclorome 450 inhibitors, prone to for drug interactions, and those are given for as a anupan, as well as there are contraindications. Many medications are given as anupan, many are contraindicated also. But what has been triggered? So what I mentioned, the monitoring will targeted whether Kakarashtak improves, worsens the biological bioavailability or neuropathy, that the specific questions can be answered with this therapeutic monitoring. So there are some these are examples how the protocols can be designed for monitoring. So we will this PPT will be there, and the protocols, preliminary protocols will also be, we will share with you, but those are to be modified. And it is not needed that all are to be all investigations and all will be applicable and all will be done. But the holistic, there may be ideal, minimal applicable standards may be there, and those may be modulated as per the need. But there are preliminary documentation pro formas for these are an examples. There are several one for observational study of Tarpan. A few examples are quoted here over how to monitor, what to document. And for therapeutic clinical trials also, some are just drafts are there over what to monitor. So I think it is over. So take home message, you can have revised AGOSI guidelines, operational guidelines for collaboration. It doesn't need, Dr. Prajit Nath sir asked me, as I mentioned, it doesn't need anything for a setup, only an enthusiasm. We are waiting for collaboration, we are waiting for you, and it is by us. It is by us. So it is not that Galib sir is will do, somebody else will do. We have to do. Otherwise, it will be for it will be for us, and it will be for others. So just give a call, just show your enthusiasm to either Pradeep sir, Galib sir are there. Yes, SURAKSHA website is there, and we are there. We are ready to for everything, for awareness, for conduction of programs, online program. It doesn't cost anything. For link, everything we will take care. Only you just show your enthusiasm, then we will proceed for. So monitor, analyze, document, publish what is being practiced is cost nothing, and more you report, more strengthen the safety assurance. Thank you. Thanks a lot. I am very much thankful to Director NPVC, Coordinator, National Coordinator Galib sir, Prajit Nath sir, Ramesh sir for giving me an opportunity to share my views. Thank you. Thanks a lot.
Thank you, sir. Now I invite Dr. Ramesh NV to present the token of love and Dr. Prashant B. Bedarkar to receive the token of love.